off with ovarian cancer, and I've written plus fallopian tube and peritoneal cancers in here because these are pretty much a single entity. They kind of behave the same way and are treated similarly. So I'll primarily refer to it as ovarian cancer, but that also includes fallopian tube and peritoneal cancers. So we'll start off with the question. This is straight up from Mixup 18, so I'm sure you guys all have access to it, but main reason is to work our way through the question and see how we get to the answer. So this is a 62-year-old woman evaluated during a follow-up visit for recently diagnosed stage 3A high-grade serous ovarian cancer. She underwent total abdominal hysterectomy and bilateral salpingo oophorectomy and completed 6 cycles of chemo with cisplatin and paclitaxel. The patient's paternal aunt was diagnosed with breast cancer at age 52. There's no personal or family history of any other cancers. She takes no medications. On physical exam, vital signs and the remainder of the exam are normal. Lab studies reveal a serum CA-125 of 14 after chemotherapy, and initially on diagnosis, it was 383. Which of the following is the next most appropriate test to perform? A, test for Lynch syndrome, B, chest radiograph annually, C, CT of the abdomen and pelvis in 3 months, D, genetic testing for BRCA1 and BRCA2 mutations. Anybody want to take a guess? Anybody else? D? Okay, so we'll work our way through it. The answer is D, genetic testing for BRCA1 and BRCA2 mutations. Okay, so a little bit of epidemiology. Ovarian cancer is the second most common gynecologic malignancy in developed countries such as the US, and it is the third most common in developing countries. Cervical cancer is still the most common in developing countries, and that's due to poor access to healthcare, vaccinations, and screening in those countries. Ovarian cancer is the most common gynecologic cancer related to death, or the most common gynecologic cancer related death. And then the average age of diagnosis in the US is 63 years old. If a woman has a hereditary ovarian cancer syndrome, she may be diagnosed at a much younger age than that. The highest prevalence is in non-Hispanic white women, and the highest mortality rate is in African American women. So I like this chart because it just kind of goes to show the different types of gynecologic cancers that we see in women. And as we can see, we've made some progress as far as uterine cancers, breast cancers, and cervical cancers. But when it comes to ovarian cancers, we still have a much higher mortality rate compared to survival. And we all know that this is because of a few factors. One, there are no screening recommendations to try to catch this at an earlier stage. And 2, unfortunately, when women do present with ovarian cancer, most of them are already advanced stage at that point. Okay, so this is from the Gynecologic International Society. And once again, this is kind of reiterating the importance of kind of working up ovarian cancers. Right now, I think this was from 2018, but at that time they had estimated around 230,000 new cases of ovarian cancer with about 150,000 deaths. And as you can see, by 2035, so in just 15 years from now, it's projected to have a 55% increase in the number of new cases with 70% increase in the number of ovarian cancer deaths. And that's pretty alarming when you kind of take into consideration all the other cancers and kind of how far we've come with that. Trying to move this. Okay. This is some data from SEERS. SEERS is a database from NCI, National Cancer Institute, and it looks at epidemiology, basically. And this one goes to show us that this year alone, there will be about close to 22,000 new cases with about 14,000 deaths. And as we can see, the 5-year survival rate is still less than 50%. So we could certainly do better with that. Okay. So moving on to histology, when we think of ovarian cancer, the one we typically think of is epithelial ovarian cancer, and that's the one that's about 90% of ovarian cancers. That's the one that you'll most commonly see. That's the one that we most commonly see. And so everything I'm going to talk about today is really epithelial ovarian cancer. I don't think you guys need to know much about the other ones, so I'm not going to go into detail with that. And in terms of epithelial ovarian cancer, the serous type is the most common one out of all the other histologic subtypes that we have. Okay. So this is just a picture from up to date looking at where these different tumors originate. And we can see that sex cord stromal tumors as well as germ cell stromal tumors both originate within the ovaries itself. And then epithelial ovarian cancers, like the name suggests, arises from the lining of the ovary itself. Okay. So we all know this, risk factors for ovarian cancer, the ones that increase your risk for developing ovarian cancer are an increasing age, particularly in postmenopausal women. Those are probably the two most strongest risk factors: infertility, null parity, endometriosis, polycystic ovarian syndrome, prior IUD use, cigarette smoking, and of course BRCA1 and BRCA2 mutations. And then the ones that decrease the risk are pregnancy, breastfeeding, and use of OCPs. I know this is such a simple slide, but I think it is important to know the risk factors, and I think it's an easily testable question, which of the factors either increase or decrease the risk. So this goes to show us that in the general population, without any risk factors, the average person or average woman in the general population has a 1.3% risk lifetime probability of developing ovarian cancer. But as we have some of these genetic mutations, especially the BRCA mutations, we can see that their lifetime risk does increase pretty significantly, and up to almost 45% in BRCA1 mutation carriers. And as you can see down here on the left side, these are just other risk factors that we went through. And certainly there is a higher relative risk in patients with infertility, history of endometriosis, and like everything, cigarette smoking. Okay, so moving on to genetics, we know the most common genes involved are both BRCA1 and BRCA2 mutations, but there's also mismatch repair genes associated with hereditary non-polyposis colon cancer, which everyone knows, also known as Lynch syndrome. And it's important to know because actually 10 to 15% of women that develop ovarian cancer will have a mutation in one of these genes, so very important to test. And any epithelial ovarian cancer should be offered genetic testing for BRCA1 and BRCA2, regardless of age, of onset, or family history. That's really important to remember, and that's actually kind of what led us to the answer in the question that we started off with. In that question stem, the patient had a history of epithelial ovarian cancer, and that's why she should have received BRCA1 and BRCA2 testing. I think the question stem did have history of an aunt with breast cancer at 62, but it's really the fact that she has epithelial ovarian cancer is why you should refer her for testing. We've kind of already went over the cumulative lifetime risks and the incidence with BRCA1 and BRCA2 mutation carriers. And MMR genes do range anywhere between 3 to 15%. So Lynch syndrome, I know you guys will probably hear this in some of the other lectures either today or in the next couple of weeks, but I think it's just important to reiterate, this is one that you guys should know inside and out because there's a whole constellation of different malignancies associated with Lynch syndrome. And the most common ones we see are colorectal and endometrial, but ovarian's in there, gastric, renal, ureter, pancreatic, all of those. And once again, I think it's a easy test question that they can have a bunch of different cancers and ask you which one is not a part of Lynch syndrome, and they can maybe put in cervical in there, not being a part of Lynch syndrome. Okay, and this pie chart just shows us that about 75% of the genetic mutations are just BRCA1 and BRCA2, so very important to remember those. Okay, so how do we screen for ovarian cancer? Well, we don't screen for ovarian cancer. There's no routine recommendations for this, even with CA-125 or transvaginal ultrasound, even in average or high-risk patients. The bottom line is there's no screening for them.
For the anyone who has the familial ovarian cancer, is there some like an indication for?
Yeah, you can. I'm actually going to go a little bit about into the. No, that's okay. So for boards, know all the USPSTF recommendations, and this is the recommendation in terms of ovarian cancer. So any woman with a personal or family history of breast, ovarian, tubal, or peritoneal cancer who may have an ancestry associated with breast cancer susceptibility, so BRCA1 and BRCA2, with an appropriate brief familial risk assessment tool, which I'll go over in a minute. And then if they are positive on this risk assessment tool, then you should refer them to a genetic counselor for further testing. So doesn't mean go ahead and screen them, but you should kind of review their family history and see if they meet the criteria to be referred with one of these genetic assessment tools. And once again, they advise against screening for ovarian cancer in asymptomatic women, or if they do not have a known high-risk hereditary cancer syndrome. So these are some of the genetic risk assessment tools that we use, and I've just kind of put them up there for reference. They all have more or less the same criteria that they use. They may have a different scoring system, but if they are positive on this tool, then that's when you want to consider referring them to a genetic counselor for further workup and possible testing at that point. And this is the Ontario Family History Assessment Tool. So this is just an example of one of those tools that I mentioned, and you can see it takes into consideration both breast cancer and ovarian cancer. And then at the bottom, it does also kind of ask family history of prostate and colon cancer. But breast and ovarian are kind of the top two that they look at, and then the degree of relatives, so either parents or siblings, and then whether they're second or third degree relatives. And then really the age at which they were diagnosed. And they have a point scoring system. And really, if they're above 10, then that's when you should go ahead and refer them to a genetic counselor. And as you can see, it doesn't take much to get to 10 points. Just having mom with breast or ovarian cancer right there alone is enough to send someone for genetic counseling. So I'm going to move on a little bit about talking about risk reduction therapies because, like I said, there's no screening, but risk reduction has helped with ovarian cancer. So all patients that have BRCA1 and BRCA2 or MMR gene mutations should be recommended to undergo prophylactic bilateral salpingo oophorectomy. And that's because studies show that this will decrease the risk of ovarian cancer, fallopian tube, and primary peritoneal cancers by 80%. That's actually huge when you compare that to all the data we went over at the beginning of the presentation with the high mortality rate in these patients. And ideally, if a woman is diagnosed with one of these mutations at a younger age, and if they're BRCA1 mutated, you recommend they undergo risk-reducing surgery by the age of 35 to 40. And if they're BRCA2, you can kind of push it out a little bit further to 40 to 45. But basically, you want to try to encourage them to complete childbearing and get the surgery done as soon as they can. People have asked, what about, well, what if somebody has ovarian cancer at age 50? Really, at that age, risk-reducing surgery has not shown to be beneficial. So really, if we can try to get them to surgery by these ages, that's optimal. Also important to note, in Lynch syndrome, we recommend both the bilateral salpingo oophorectomy as well as hysterectomy, and that's because we know Lynch syndrome also has increased risk of endometrial cancer. So doing that additional hysterectomy will kind of help decrease the risk of endometrial cancer in these patients. OCPs do reduce the risk of ovarian cancer by 40 to 50%. Greatest benefit is seen after 15 years, but remember, it can also increase the risk of breast cancer. So you kind of have to take that into consideration. Okay. So as far as clinical presentation goes, oh, sorry.
As far as like breast
reduction. Yeah, I have a slide on that. That's okay. So you may have women present with acute symptoms, which include pleural effusions, ascites or bowel obstruction, or subacute symptoms, abdominal pelvic pain, adnexal mass, urinary frequency, or early satiety or bloating. So really, if there's no clear etiology for any of these symptoms and they're kind of ongoing, then we should do further workup. So initial studies we all know is a general physical exam, a thorough pelvic exam, and basic labs including CBC, CMP, and CA125. We also do transvaginal and transabdominal ultrasounds to look for the presence of an adnexal mass. And then if there is suspicion of further disease, always do further imaging, CT, chest, abdomen, and pelvis, or you can do MRI or PET, depending on what the suspicion is. And if there is concern that this could be a possible genetic association, then go ahead and refer them to the genetic counselor. So now kind of, you know, most malignancies we think about, okay, we see a mass, we're going to go ahead and biopsy it. Ovarian cancer is a little bit different because we actually want to try to remove the mass, especially if we see something on imaging. And so the question becomes, do we go ahead and proceed with surgery, or do we do a biopsy in these patients? And so really that's when we get our gyn-onc colleagues involved, because we need a pathologic diagnosis. Imaging will assess if there is an adnexal mass or not. Sometimes you may not have a mass present on imaging, but they still can have ovarian cancer. We also do imaging to make sure that this is not a metastatic lesion from somewhere else. There's no synchronous primaries or another extra ovarian primary malignancy. And 5 to 30% of ovarian cancers are actually metastatic, and the most common sites are breast and GI. So we all know gastric cancer and Krukenberg tumor. So when we've done imaging and we're suspecting that this is an early stage ovarian cancer, go ahead and proceed with diagnostic surgical exploration. So that's when gyn-onc will go ahead and they will remove the ovaries intact because incision may rupture the mass, and this can actually lead to peritoneal seeding and a more advanced stage of the tumor. Image-guided biopsy is not typically done. The few instances in which we do it is if the patient has poor performance status and a lot of comorbidities which preclude them from having a surgery, or if we kind of already know from imaging that they have advanced disease. So if we're already seeing signs of ascites, pleural effusions, things like that, we kind of already know that it's spread beyond just the ovaries. And so, like the last part says, if it is advanced disease, you can go ahead and do a thoracentesis, paracentesis, or an image-guided biopsy. In terms of staging and treatment, so a lot of these patients do undergo upfront surgery, and that helps us with staging and kind of how to follow up with that. So surgical staging and cytoreduction followed by adjuvant chemo is kind of the standard, general standard that you should remember for most patients. And the standard surgery they do is a total hysterectomy with bilateral salpingo-oophorectomy with pelvic and para-aortic lymph node dissections. They can also, when they go in intraoperatively, look for any involvement of the omentum, and they may do pelvic washings, remove the omentum if necessary. If there is disease elsewhere, the surgeon may also do a partial bowel or partial hepatic resection. So I'm a visual learner, so I put this slide in here, but when it comes to staging, we'll just kind of go through each of the stages. So up here in the top left-hand corner is stage 1. This is obviously the simple one to remember. It's when cancer is either in one or both of the ovaries, but the main thing is that it's confined to the ovaries. It has not spread beyond the ovaries. This green box here shows us stage 2, and this is when cancer has spread beyond one or both ovaries to other nearby organs, such as the uterus or bladder. Stage 3 is when it's in nearby organs, the lining of the abdomen, or as we can see, lymph node involvement. And then stage 4, we all know, is when there is distant metastatic spread. This you guys don't have to know. This is simply just kind of in there as a reference, but this is the TNM staging that we use. And really staging is kind of what we use to determine what treatment they're going to undergo. Okay, so I'm going to talk about a little bit about when we use neoadjuvant chemotherapy versus when we do primary debulking surgery. So we already know in early stage disease, we go ahead and do primary debulking surgery. But if you have a poor surgical candidate that we cannot do surgery on, or the mass is so large that the surgeon feels that they cannot do optimal debulking, which is when they have less than 1 centimeter of the tumor left after the surgery, then they typically reach out to us and ask us, hey, can you guys give this patient some neoadjuvant chemo so we can do optimal debulking? And then in some patients, when you're considering neoadjuvant chemotherapy, we may do a biopsy for diagnostic purposes to determine if the patient should have surgery or neoadjuvant therapy. And in some patients, when they are a candidate for surgery and we're giving neoadjuvant chemo, we typically will do 3 cycles of chemo, repeat imaging, see if they can optimally be debulked at that time. If they can, the surgeon will take them to the OR, and then we'll finish the other 3 cycles of chemotherapy. So this is the NCCN guidelines. It was actually updated earlier this year for stage 1, and down here we have stage 1 to 4. And up here, stage 1 and stage 1B is really if it's a young woman that wants to preserve fertility, they usually just undergo a unilateral salpingo oophorectomy. Stage B is when you have involvement of both of the ovaries, so they do need to undergo a bilateral salpingo oophorectomy. But really, anywhere from stage 1 to stage 4, surgery is the standard of care. If you can't do surgery, then we do chemo up front. And if you cannot do any surgery at all, such as patients with poor surgical candidates, we only give them chemo. And so once they've received chemo, if they've had response, we can do the interval debulking like I talked about. If they have stable disease, we may complete the rest of the chemo and then go on with surgery. If they have progressive disease, we change treatment. This is actually from, I think, MixApp 18. So this is probably a good table for you guys to kind of look at in terms of what the treatment modalities are. So you know if it's early stage, you're going to do surgery alone. If it's stage 1 or stage 2, an unfavorable category, then we can go ahead and start off with chemotherapy. If it's stage 3 and they've already been debulked, we give them adjuvant chemotherapy. And if they're suboptimally debulked or they're stage 4 disease, it's usually chemo. The interesting thing I want to point out here is most stage 4 cancers, we don't do any sort of surgery, but in ovarian cancer, we actually will still do surgery in stage 4 to try to remove the primary tumor because that does improve the overall survival. So they'll still get surgery and then they'll get chemotherapy after that. Okay, so in terms of monitoring and surveillance, if you had someone that's undergone treatment, they're in complete remission, then typically we'll do physical exam. And actually, it's not really us, it's usually Gynonc that follows these patients, but they'll do exams every 3 to 6 months for about 5 years and then annually. NCCN has a little bit of a recommendation. They will do exams every 2 to 4 months for 2 years, then space it out to 3 to 6 months for 3 years, and then they'll continue annually after that. Now, in terms of CA 125, there's not really a clear role to monitor that routinely. The studies show that there has been no improvement in survival by monitoring patients with CA 125, but some of the surgeons do feel that if their CA 125 was elevated prior to surgery and it's decreased appropriately after surgery, then they do still monitor the level. And once again, there's no recommendation for any routine imaging if the patient's in remission, unless there are signs or symptoms worrisome for recurrence of the disease. Okay, so to your question about...
Duck. Oh my goodness.
Okay,
I saw
so
tiger.
had a question about breast cancer risk. So typically when we have breast cancer patients that have BRCA1 and BRCA2 mutations, we recommend them to undergo prophylactic bilateral salpingo oophorectomy. but it does not exactly work the same when you flip it. So if you have someone with ovarian
What does the
cancer,
snake say?
we don't recommend them to undergo mastectomy if they have BRCA1 or BRCA2 mutations. And that's because really there hasn't been much consensus on appropriate management, and really prophylactic mastectomy is just not done. So really right now the best things you guys can do is clinical exam, mammograms as they're due for it. If there's higher suspicion, then you can go ahead and refer them to gynecology. In terms of recurrence, so there is a high rate of recurrence. About 80 to 85% of women with stage 3 or 4 will relapse at some point. And really the timing of relapse is important to determine next line of therapy, because if their relapse occurs more than 6 months after their initial chemotherapy, then they're platinum sensitive. The initial chemo that we give these patients is carbotaxol, so they can receive platinum agents again to see if we can get their disease under control. If their relapse was less than 6 months, they're actually considered platinum refractory.
What did you say, baby?
And we typically don't.
Yes, I saw a peacock once. Your name is Wanahakalugi.
That's okay. Okay. So if their disease is within, relapses within 6 months, they're platinum refractory, and then we have to move to single agent chemo. We've had recent studies that show the addition of VEGF inhibitors, bevacizumab, which you guys may have heard of, and some of the other malignancies, has shown to improve disease-free survival, but not overall survival. And then in patients with BRCA1 and BRCA2 mutations, recently we've had approval for PARP inhibitors such as olaparib and a few other ones that we can now give once they've progressed on chemotherapy. So the two most common chemo agents we give are carbo and Taxol. I'm not going to go into all of the other subsequent ones. And this I just kind of put in for you guys for might be useful in clinical practice. PARP inhibitors, we have olaparib, which is approved in BRCA mutated ovarian cancer, and then rucaparib and niraparib are both approved regardless of the BRCA status. And these PARP inhibitors, I don't know if anybody's talking about prostate cancer later on, but they might come up again for that. And then as far as immune checkpoint inhibitors, I know you guys know we use it in a lot of different types of malignancies. It's not approved yet, but pembrolizumab can be considered if there's really no other options and they have the MMR deficient gene. Just wanted to go over some side effects. PARP inhibitors have horrible nausea, vomiting, and fatigue. We've actually had to stop patients from their PARP inhibitors because of these side effects. And then you also see anemia, neutropenia, and myelosuppression. VEGF inhibitors I thought was important to put in there because there is high risk of hypertension, risk of hemorrhage, arterial clots, GI perforation, life-threatening GI perforation where they may not be able to go in and actually fix that, and the patient is going to subsequently pass from that perforation, as well as impaired wound healing. Okay, and so just to conclude a little bit about survivorship and quality of life. These women, you know, they go through a lot. They undergo extensive surgery. They have a lot of side effects from chemotherapy, including a cognitive dysfunction, numbness, weakness. A lot of them will have GI symptoms, including bowel dysfunction. A lot of sexual dysfunction, fertility loss, which is really challenging to deal with in the younger women, anxiety, depression. And so, you know, we obviously promote healthy diet, exercise, limit alcohol intake. Okay, so now I'm going to move on to cervical cancer. So we'll start off with another question again. 42-year-old woman is evaluated during a follow-up visit for stage 2A cervical squamous cell cancer. She has completed therapy with pelvic external beam radiation and concomitant weekly cisplatin chemo with cervical brachytherapy added during the 4th week of therapy. She has had an excellent response to treatment and is otherwise well and takes no medications. On physical exam, vital signs are normal, pelvic exam reveals no evidence of tumor, and the remainder of the exam is normal. So which of the following is the most appropriate post-treatment surveillance for this patient? CT and of the pelvis every 6 months, complete blood counts, serum chemistry, liver chemistry every 3 months, history and physical with gyne exam every 3 months, or pelvic ultrasound every 6 months. Anybody? Yeah. So C is the answer, and we'll kind of go over that. So cervical cancer is the second most common cause of cancer-related mortality in women worldwide. Mean age of diagnosis in the U.S. is about 48 years old. There's going to be approximately 14,000 new cases in the U.S. every year, with about 4,300 cervical cancer-related deaths. Once again, non-Hispanic whites have the highest incidence, but with cervical cancer, they also have the highest mortality rate. And as we know, over the last 30 years, incidence and mortality has both decreased by more than 50% in developed countries. And we know this is due to increased screening and prevention with HPV vaccination. And more than 85% of cervical cancer-related deaths occur in less developed countries. So once again, this is a SEER data for 2020, I believe, from NCI, looking at the incidence and survival. And this year, there's a estimated incidence of about close to 14,000 cases with close to 4,300 cervical cancer-related deaths. And in this one, we can see the 5-year survival rate is a little bit better than what we saw with ovarian cancer, which was about 48%. This map is just kind of going over incidence and mortality kind of all over the world. And as we can see, the higher rates of incidence of cervical cancer are all throughout Africa and then in South America. And mortality kind of mimics that similar pattern due to access of vaccination and proper healthcare and screening. They have higher incidence and mortality. Okay, so in terms of risk factors, HPV is probably the most important one to remember, and that's because almost 99.7% of cervical cancers have an association with HPV. Also, earlier onset of sexual activity, multiple sexual partners, immunosuppression and HIV infections, low socioeconomic status and poor access to healthcare, OCP use, prior history of STDs, obesity, cigarette smoking, and family history are all going to be risk factors for cervical cancer. So luckily, cervical cancer, we do have screening, and we have seen that screening is useful. I know you guys kind of already know this, so I'll quickly go through it. In women that are less than 21 and they're asymptomatic and immunocompetent, you don't screen them regardless of the age of onset of sexual activity. Women that are 25 to 30, we have two options, either PAP alone every 3 years, or we can do PAP with HPV every 5 years. And then women that are above 30, we can do co-testing with PAP and HPV every 5 years, primary HPV testing every 5 years, PAP with reflex to HPV testing every 3 years, or PAP alone every 3 years. And these are just different societies and kind of their guidelines as far as when to initiate screening and discontinue, and kind of what tests to do in between. But for your boards, you should know the USPSTF recommendations, which I've highlighted in red, and they kind of mimic what we just went over, to start screening at age 21, and you can discontinue at 65 if they've had adequate pap smears before that. Once again, this is the same thing from USPSTF with that recommendation, so I'm not going to go over that. But what I do want to point out is this recommendation here, right here, which is advising against screening for cervical cancer in patients that have had a hysterectomy with removal of the cervix and did not have a high-grade precancerous lesion or cervical cancer. Now, in terms of vaccination, this is from the Advisory Committee on Immunization Practices. So the guidelines say to vaccinate boys and girls between ages 11 to 12. And then if they're not vaccinated by then you can give them a vaccine between ages 13 to 26. Ideally, the goal is to try to get the vaccine in them before onset of sexual activity. And we really don't recommend HPV vaccination after age 27. If adolescents get the vaccine before age 15, usually it's a 2-dose series. And if it's after age 15, it's a 3-dose series. Gardasil, I think, is the most common one that we use, and Gardasil 9 covers a lot of the high-risk oncogenic types that we see up here. The low-risk ones that we're all familiar with are HPV 6 and 11, so Gardasil covers at least those, plus 16 and 18, which are high risk, as well as a couple of the other ones in the 30s. I can't remember those off the top of my head. Okay, so in terms of histology, squamous cell carcinoma is the most common one we see, followed by adenocarcinoma, and then there are a few other variants that are pretty rare. We don't typically see those. Okay, so this picture depicts the kind of how we go from a normal epithelium into transitioning into carcinoma. So starting on the left, we can see that that's a normal cervix, and this patient has been infected with HPV. And so now you go into low-grade squamous intraepithelial lesion. And really, if you look at the bottom, 93% of these patients can clear their HPV infection by 3 years. But if they don't clear it, then they can go ahead and progress onto high-grade squamous intraepithelial lesions, and risk factors will be STDs, HIV, smoking, immunosuppression, some of those that are present up front, and then eventually they can transform into a carcinoma. But really going from a low-grade squamous intraepithelial lesion up to carcinoma does take quite some time, anywhere between about 12 to 15 years. And so that's why HPV screening and doing the pap smears is important to try to catch these patients when they're earlier on in this. And this picture just kind of depicts the histology from normal epithelium to low grade to high grade to cervical cancer. Okay, so some of the symptoms that we watch out for are abnormal vaginal bleeding, postcoital bleeding, vaginal discharge or odor, pain with intercourse, bowel or bladder symptoms, or pelvic or back pain. And so, some of these symptoms are pretty vague: pelvic or back pain, bowel, bladder symptoms. And so really, if there's no other etiology, then you want to maybe think about cervical cancer. I know you guys already all know how to kind of interpret PAPs, so I'm not going to go into too much detail with that. But if you do a pap smear and there's suspicion for cancer, then follow up with a colposcopy and biopsy to confirm that. When you're doing a pelvic exam, if there's a direct visible lesion, you can go ahead and directly biopsy that. And if there's an abnormal pap or no visible lesion, then we typically do cervical conization or LEAP. So this is going through the stages of cervical cancer. So starting off in the left, stage 1 cervical cancer is when it is typically limited only to the cervix. Stage 2 is when cancer cells have spread to the upper part of the vagina or to tissues around the uterus. Stage 3 is when we start involving the pelvic sidewall, and cells may have spread to local lymph nodes in the pelvic area. And stage 4 is when we have distant spread to other organs, so liver, lungs, and things like that. So this is from NCCN guidelines updated earlier this year. And the way they kind of do their staging for cervical cancer is a little bit weird. And that's because you can see I've separated this into 2 parts, the top red and the bottom green, and you can see it kind of, the top is actually early stage cervical cancer, and the bottom half is really more advanced cervical cancer. And really this 1B2 to 1B3 is where they kind of make that distinguishment. Okay, so moving on to treatment. So first I'll talk a little bit about early stage cervical cancer, and then we'll go on to more advanced stage. So early stage, like I said, is everything up here, anywhere between stage 1A to stage 1B2. And in these patients, if they're very, very early stage, we can typically just get away with doing a cone biopsy, or you can be a little bit more advanced with the hysterectomy. If there are high risk factors present on the pathology, then we do follow up with a modified radical hysterectomy. Moving on to stage 1A2 and 1B, modified radical hysterectomy, also with pelvic lymphadenectomy is kind of the standard. And then for 1B2, you kind of do the same thing. So when do we give these patients adjuvant chemoradiation? So really, if they have high risk factors, which includes tumor size above 4 centimeters, they have lymphovascular space invasion or deep stromal invasion, pathologically involved lymph nodes, or positive surgical margins is when we begin to add further treatment beyond just surgery. Now, the later stages of cervical cancer, which we said are right here, stage 1B3 and kind of beyond, is really when the tumor is more than 4 centimeters in size or is extending beyond the cervix. And really, they have several options as far as treatment goes, but primary chemoradiation is really what we prefer. You can do neoadjuvant chemotherapy followed by surgery or radiation therapy, but standard is really primary chemoradiation. During radiation, patients will typically get weekly cisplatin. And then the other thing is, because they're more advanced stage, we do a PET scan to see if there's para-aortic lymph node involvement. And if there is suspicion for it, we do biopsy it either with a lymphadenectomy or a CT-guided biopsy to see if there is spread of the cancer there. If there is, then typically the radiation oncologist will extend the field of their radiation therapy to include those lymph nodes. And most experts suggest not to do a post-treatment hysterectomy after chemoradiation, but some studies say that they're still doing that if the initial tumor size is more than 7 centimeters, there's involvement of the lower uterine segment, or there was a high post-treatment residual volume. So this slide is basically from MixApp 18, and kind of just as a general rule, I guess, if you have an early stage, think about doing surgery. If they kind of fall in the middle between stage 2 to 3, we typically do chemoradiation. And then, of course, as they become more advanced into stage 4, we typically do surgery. So I just want to go a little bit into cisplatin. You guys will hear it with a bunch of other cancers. Main side effects we worry about are nephrotoxicity and neuropathy. In some of these patients with cervical cancer, patients may present with acute renal failure, and that's because they may have tumor-related hydronephrosis. So if we go ahead and stent them, we can often see that this will relieve the obstruction, and they can still receive cisplatin. If they can't get cisplatin, we usually give carboplatin or gemcitabine. And this is another chart from UpToDate. This one is actually a little bit older, just going over prognosis of cervical cancer. And as you can see, the earlier on we are, prognosis 5 years out, they tend to do very well. And as we go on to stage 4, prognosis is very dismal. So in terms of post-treatment surveillance, one of the main things we want to do is try to detect recurrence of the cancer early, especially because they may be amenable to curative therapy if they do relapse. And so the standard is really to do a history and physical exam, including a thorough pelvic exam. Once again, we don't really do them, but the gynecs will typically do that. And then we don't really do any imaging unless there is symptoms or concerns of recurrence. And so just kind of want to end with a little bit about survivorship in cervical cancer patients. So just like ovarian cancer, these women go through a lot, go through extensive surgery, go through a lot of chemotherapy, and there are a lot of psychological, mental, physical, just overall issues that they kind of undergo through, and we have to be very mindful of them when it comes to that. And that's it. Any questions?
Mm-hmm. Why exactly